Good evening and welcome. I am Digvir Jayas, Vice President Research and International at the University of Manitoba. I would like to begin by acknowledging that the University of Manitoba is on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Welcome to this evening's topic for a discussion that shares the approach and learnings of the Institute for Global Public Health on 2 continents. They have been working for the past 2 decades to improve the health outcomes among vulnerable populations and endeavoring to leave no one behind, even throughout a global pandemic. I'm sure most of you tuning in have heard of the United Nations Sustainable Development Goals. What you may not know is that the University of Manitoba is a member of United Nations Academic Impact or UNAI. This initiative aligns more than 1,400 member institutions of higher education around the world with the UN in supporting and contributing to the realization of their goals and mandate, including the promotion and protection of human rights, access to education, sustainability, and conflict resolution. The work of these institutions is vital to achieving the Sustainable Development Goals, as they serve as incubators of new ideas and solutions to the many global challenges. The work of the Institute for Global Public Health aligns with many of the Sustainable Development Goals. I will turn things over to your moderator this evening, Dr. Maryanne Crockett. Dr. Crockett is an Associate Professor of Pediatrics and Child Health, Medical Microbiology and Infectious Diseases, and Community Health Sciences at the University of Manitoba. She moved to Winnipeg from Kenya in 2007 and now combines her clinical pediatric infectious diseases focus in Manitoba with her global health work as the Director of Research and Knowledge Translation at the University of Manitoba's Institute for Global Public Health. Dr. Crockett will introduce our panel for tonight. I'm certain you will keep them busy with many questions. They will be happy to share their knowledge. Thank you. Back to you, Dr. Crockett.
Thank you, Dr. Jayas. I'll give a quick overview of how we plan to proceed in our online Café Scientifique format. Each of our panelists will speak briefly on their perspective based on their expertise on tonight's topic for discussion. I will then open up things for questions, and questions can be posed via Slido. And I think the information for that is being shown to you right now. There's a link in the YouTube description in this feed you're watching and also on the screen throughout the discussion. You don't need to download software to use the application, just an internet browser and the discussion code. I'll be moderating questions from Slido as well as the interactions with our panelists this evening. So this brings us to tonight's expert panel. They are Dr. James Blanchard, Dr. Vasanth, and Parinita Bhattacharjee. I'll go through the introductions and then we have a special treat for you tonight. The first speaker, Dr. James Blanchard, is an epidemiologist and public health specialist focusing on global health. He received an MD from the University of Manitoba and an MPH and PhD in epidemiology from the Johns Hopkins University. He is a professor and the executive director of the University of Manitoba's Institute for Global Public Health, or IGPH for short, and holds a Canada Research Chair in Epidemiology and Global Public Health. His research focuses on how the characteristics of individuals, communities, and large populations contribute to the local and global distribution of communicable and non-communicable diseases. Over the past 25 years, he has also provided leadership to the design and implementation of large public health programs related to sexually transmitted infections, HIV, AIDS, and maternal, neonatal, and child health focused in South Asia and Africa. Our second speaker is Dr. Vasant. He is a faculty member at the University of Manitoba, Community Health Sciences Department, and is the Executive Director of the Uttar Pradesh Technical Support Unit, or UPTSU as we call it affectionately, the project which is located in Lucknow, India. He has an MD, Internal Medicine, MPP from Princeton, and MPH from Johns Hopkins degrees by training, and is also a civil servant in the Indian Administrative Services, members of which occupy senior leadership positions. Welcome, Vasant. And our third speaker is Parinita Bhattacharjee. Parinita is based in Nairobi, Kenya, and has 25 years of professional experience in the global health sector, ranging from HIV and AIDS to sexual and reproductive health and disability. She's held leadership roles across large-scale intervention projects with key populations funded by Bill and Melinda Gates Foundation, USAID, CEDA, and the Government of India. She has also provided technical support to more than 10 African countries to scale up key population programs, more recently through the Global Prevention Coalition-led South-to-South Learning Network. She currently also provides technical support to the Ministry of Health in Kenya, where she's based, to scale up key populations programs. As the Director of Program Delivery at the Institute for Global Public Health, her role is to lead development of global health program design and delivery across the focus geographies with marginalized populations in partnership with government, civil society organizations, academic institutions, and communities. Just want to thank especially Dr. Vasant and Parinita for joining us, because it is very early for Dr. Vasant and it is in the middle of the night for Parinita. So we really appreciate that they're joining us and sharing their knowledge and their expertise with us for the conversation this evening. We actually have a special treat tonight. We're going to watch a short video that was created to give a bit of an overview about the UPTSU that Dr. Vasant will be talking about a bit more later.
Gudiya is the mother of a 5-week-old baby girl. With the assistance of Girija, a frontline worker, and Aarti, a community resource person for the Uttar Pradesh Technical Support Unit, Gudiya is learning about the importance of ongoing exclusive breastfeeding for her infant daughter. In Uttar Pradesh, India, where 50 of every 1,000 infants die before reaching their first birthday, breastfeeding is an essential step towards reducing infant mortality. Since 2014, the Uttar Pradesh Technical Support Unit has been providing support to the government to plan, implement, and monitor their reproductive, maternal, newborn, child, and adolescent health programs. Community resource persons like Aarti and nurse mentors who work closely with frontline workers are an important part of the TSU's work in improving the lives of women, children, families, and communities in Uttar Pradesh, India.
Thank you. So now we'll have Jamie Blanchard talk.
Thanks, Maryanne, and thanks to everybody for participating. And I also wanted to echo thanks to Parinita and Vasant for taking time out of their schedule at awkward times for them for joining us. But it's really great to have you here. And I'm really looking forward to our conversation this evening. And as Digger introduced, In 2015, the United Nations member states adopted a 2030 agenda for sustainable development. And it was described as this blueprint for peace and prosperity for people and the planet now and into the future. And this was a very ambitious agenda. It included 17 sustainable development goals. Each of the goals had targets for achieving progress by the year 2030. And out of these 17 sustainable development goals, the third sustainable development goal was focused on health and well-being. And it was expressed as the goal to ensure healthy lives, and promote well-being for all and at all ages. And each of the development goals has targets, and the kinds of targets they had under the third sustainable development goal were things like reducing global maternal mortality to less than 70 per 100,000. It's currently over 200 or around 200 today. So an ambitious goal for 2030. But also more diverse health system types of goals, like the achievement of universal health coverage by 2030 was another one of the sustainable development goals under health. And one of the things that is quite remarkable is that now, if you look at how countries are organizing their efforts around health, many of them are focusing their efforts around strategies to achieve their sustainable development goals. And so in many of the conversations with policymakers or leaders, you hear them talk about what their country's sustainable development goals are and thinking about how they're going to make progress towards them. So this is a huge agenda. And the question might arise, what role could the University of Manitoba play in supporting progress towards the sustainable development goals, not just in health, but in other areas? And I think reflecting on what Dr. Jayas had said earlier, the University of Manitoba really is committed to these ideals and also to supporting progress here. In fact, if you think about the mission of the University of Manitoba, it very much embodies this. And the mission of the university, just to remind those of you who don't know, is to create, preserve, communicate, and apply knowledge, contributing to the cultural, social, and economic well-being of the people of Manitoba, Canada, and the world. And so two things about that. One is that what we do in academia, what we do at the university, when we're developing or creating knowledge and preserving and communicating and applying knowledge, it really has a purpose. It has a purpose beyond just educating the next generation of students, but it has a purpose of actually contributing to well-being, which is really at the core of the Sustainable Development Goals. The second component I would mention is that the mission is not just a mission for our own community. It's a mission that considers the University of Manitoba's role and contribution, not just in Manitoba, but in Canada and the world. And I think those that part of the mission is really at the core of what we're trying to achieve in global health. As Dr. Jayas pointed out, last year, the University of Manitoba approved the establishment of an Institute for Global Public Health, the IGPH, as we affectionately call it now. Now, the IGPH builds on decades of work that the University of Manitoba faculty members, students have conducted around the world. This is not a new enterprise for us. But the idea behind the establishment of the Institute was to try to combine efforts and organize our efforts in a way that would bring further strength, borrow strength from different departments within the faculty and across different faculties to support this broad agenda. And when we think about the overall goal of the IGPH, it really is to improve health equity in our global interactions. So I would say that one of the things we might want to talk about this evening is how the University of Manitoba's approach to global health is somewhat different from other academic global health centers and institutes. And I want to sort of highlight that, and you might get a flavor of that in the conversations that we have with Vasant and Parinita as well. And I think that one of the ways that we're different is that we focus very much on working closely with public health programs and communities in different countries, thinking about what their goals are and how we can support them in achieving that. And this requires extended engagements. So instead of flitting from project to project or research study to research study, the way that we try to embody this long-term agenda to achieving goals is by having sustained engagements and partnerships over long periods of time, because a lot of the problems obviously are not going to be achieved within a short time period. Another key feature of what we do is taking mutual accountability for the public health results. Very often, academia and academics sort of take a very hands-off approach to our engagement. We're there to provide the research, the science, and let others sort of apply it. Whereas I think that what our institute has done over the years is we've actually taken mutual accountability. So when we partner with a public health program or with a community, we try to understand what are they trying to achieve, what are their goals, and how can we achieve those goals together. And so that accountability for public health results really drives everything we do. All of the research we do, all of the education that we do, all of the technical support that we apply is really around trying to support achievement of the goals that aren't our goals, they're the goals of our partners. Structurally, we focus, because we want to have sustained engagements, we've tried to emphasize a focus on particular geographies or countries. And so we primarily have focused on 4 countries, India, Kenya, Pakistan, and Nigeria. We'll have leadership from 2 of our main countries of focus speaking this evening. But I would say that we have worked in many countries. So out of these core country partnerships, we've worked in several dozen or a few dozen different countries around Africa, South Asia, Southeast Asia, and Latin America and the Caribbean. But these are our focus countries where we have long-standing partnerships and relationships. We focus on a range of health issues. Initially, a lot of our focus had been on communicable diseases, particularly HIV and other sexually transmitted infections. But over time, we've really expanded our scope to focus on a broader set of health issues like reproductive, maternal, newborn, and child health and adolescent health, tuberculosis. Very recently, our teams were very engaged in the response to the COVID pandemic. And increasingly, a lot of our focus is on health system strengthening. As you start working with governments and government programs, you realize that a lot of the fundamental changes are going to have to come through the strengthening of health systems. So a lot of our focus is now on strengthening health systems and thinking about how universal health coverage can be achieved in different contexts. And one of the major initiatives we have that is focusing on the multi-country approaches to improving health systems is our countdown. The countdown to 2030 for maternal, newborn, and child and adolescents health is an initiative that's led out of our institute by Dr. Tis Burma, who's the global director of the Countdown to 2030 for maternal, newborn, and child and adolescent health. So that's just a very brief overview of the Institute. Our next 2 speakers are going to talk more specifically about some of their experiences in some of the work that the IGPH does, and then I'm anticipating that we'll have opportunities for some great conversation thereafter. Thank you.
Thanks, Jamie. And so Dr. Vasantha is going to share with us now from India, where it is very, very early in the morning.
Thanks, Maryanne. Thanks, Jamie, for that introduction. So picking cue from what Jamie told a little bit about Uttar Pradesh, for whom do not know much about UP, the population is around 240 million. It's the most populous state in India with high MMR and neonatal mortality rate. So, like, what approach we take based on what Jamie described, we call it as program science approach, where it's a systematic application of theoretical and empirical knowledge to optimize the scale, quality, and impact of public health programs. So what does it generally mean is that we adopt the goals set by the government itself. In this case, it's SDG goal. So it's constant almost across the world for all governments, whatever level you start. So we adopt the same goals which has been fixed by the government. And as Jamie told, we take clear ownership responsibility in terms of helping government achieve that particular goal. We provide that by an embedded nature here at all levels, And we not only physically co-located, we try to imbibe their culture and with long-term partnerships so that the ability to influence them with correct technical advice is better when we are more embedded in nature. We don't do parallel programming unlike other research programs. And we also work across the continuum of care because health, particularly, there's a journey in maternal health, right from eligible couple to pregnant women to delivery to post delivery, etc. So we kind of try to provide our technical advice across the continuum of care and not pick up only small areas. We also try to provide our technical support across platforms in the context of India. Like, say, for example, antenatal care is provided through a community platform closer to the community. And then you have the delivery, which is like institutional delivery. So we work on the community platform, the facility platform. And as Jimmy was telling, to deliver these services efficiently, we also work on the health systems platform, which is one of the core aspects of it. And we rely a lot on partnerships. While IGPH and University of Manitoba plays a crucial role in UPTSU, we also provide the platform for multiple academic institutions, other agencies like Johns Hopkins or JHU, or any particular institutions and entities located both in the country and outside the country to come and work in a seamless manner so that the good quality technical support can be given. Just a flare of it, we started in 2014, as the video showed. At that point of time, any antenatal care, at least one antenatal care was only around 40%, and now it's almost universal with almost 3+ going up to 70%. So it was purely by the technical support that we gave, where we identified a platform closer to the community where women can access services. When we started with that, the next logical step was to identify how to create safe delivery and identify complication cases. So that was done through an intervention, which again, University of Manitoba IGPH kind of forwarded it in terms of mentoring the nurses who are there in the facilities who do the delivery. And this particular intervention was also scaled up. The one important, again, another approach is we try like a learning labs. We work in 25 out of the 75 districts, and successful interventions are transitioned on to the government. Now, based on our experience in 100 facilities, this nurse mentoring intervention was scaled up across GOUP by the funding support from the government itself. So we were able to train the nurses in terms of safe deliveries and identify complications, which now leads to the next problem in terms of ability to treat those complicated cases in terms of whether you need a cesarean section or a newborn complications. How do you ensure adequate capacity within the system to treat these complications, for which again you need right from human resources to equipments, etc. So on the areas of intervention, we have, apart from the program verticals, we have a strong network of human resource for health, supply chain management, digital, and data for decision making. Ultimately, the idea is to use data because we need a good quality data and make every decision based on credible data. And one important thing that we acknowledge is there are persistent challenges. And for those persistent challenges, we again go through implementation research route, which again University of Manitoba IGPH kind of pioneers it in terms of how do you continuously do it in an iterative manner implementation research for these complex persistent problems. And last point that I would like to make is we look forward into the future. We think that this kind of technical support units are required for any government or public health service, whether it's run predominantly by the government or by the private like the US system. These innovation hubs are required for government. And we also think that there is an opportunity to use UPTSU as a platform where research is much more focused for the programs rather than a pipeline approach where you do research and you expect to get it implemented. And most importantly, also about academia collaboration for students who can learn from the program. Such a large program, it's the technical support unit is more than 1,000 people embedded across system and provides across a length and breadth and depth of the entire continuum of care. Thank you very much. I'll be happy to answer any question. I'll leave it back to Maryanne. Thank you.
Thank you, Vasant. That was an excellent summary of a lot of work and effort that's been done by the UPTSU and the many people there, along with the government and other partners. So I come to our last speaker, who really is the star because it's the middle of her night. We thank Parinita very much for waking up to join us from Nairobi, and I will let you tell us about the programs you're going to speak with. Parinita, you need to unmute yourself. Great.
Over to you. Can you hear me?
Okay. Yes, we can hear you now.
Okay, I was just moving on to Kenya. We are a country in East Africa, and University of Manitoba has been working in Kenya for more than 35 years now. The approach that we use in Kenya is similar to other countries where IGPH is working, and Vasant touched upon it, is our program science approach. And this approach provides an iterative, multi-phase research in a program framework within which scientists, program implementers, policymakers work together so that practice informs research and research informs practice. The interesting part of this approach is also that it requires partnership between policymakers, program leaders, service providers, researchers, and communities that we serve. And this combined effort results in a focus on ensuring maximum population level benefit of a program through detailed understanding of the local needs and context. So our work in Kenya focuses largely on HIV prevention, care and treatment, maternal and child health, and adolescent health. And we have used two key strategies in program delivery. One is direct implementation through delivery of large-scale interventions. You may have heard at least about the swap clinics that we run in Nairobi, or also through innovative demonstration or learning interventions. We just recently concluded learning interventions with HIV self-testing with men who have sex with men. The other key strategy is technical support for implementation and delivery of programs, very similar to what Vasant said. We provide technical support to national government and other implementers. We have an embedded technical support unit within the National AIDS and STI Control Program, which is a division under Ministry of Health and has a responsibility to implement health sector response for HIV. In Kenya, we have prioritized marginalized sexual and men who have sex with men, transgender people in our interventions, because they are the most vulnerable and have the highest need for high quality health services, especially if you look at HIV and sexual and reproductive health. Besides health needs, these populations have other needs. So our program in Kenya have not only focused on increasing availability and accessibility to health services, but have also addressed structural barriers related to gender, age, sexuality, especially focusing on stigma and violence that hamper access to services. And these interventions use an equity lens especially related to marginalized populations. Just touching a little bit on COVID, that these were also the populations who were most impacted by the COVID pandemic. During the pandemic, our work in Kenya had to be adapted to not only provide direct support to the populations we work, including generating resources for food baskets or other support, as many of the key populations did lose their prime source of income. But we also supported the national and the county government to ensure that policies and programs are developed to address the impact of the pandemic. And the policies that are developed or implemented also consider the needs of these populations that we serve. The University of Manitoba research team was one of the first teams to also write papers to share the devastating impact of the pandemic on the key populations, and also recommend policy and programming recommendations. Many of the papers that we wrote were led by key population leaders who shared their resilience and program adaptations. I'll hand it over to Maryanne. Over to you.
Thank you, Parinita. I think you had a little bit of a pause, but I think we got what you were saying. So forgive me if I'm dismissing them, but
Sorry.
I'd just like to thank all of the presenters for sharing just a little bit of what they do, a bit of insight into what they do. And I don't see any questions coming. So I will take the moderator's prerogative to ask some that I have. Perhaps we'll leave Parinita for now since she may be having some issues. I have a question from one of our colleagues actually in Pakistan who sent it to me earlier, and this could be for any of you. So let's maybe we'll start with Jamie, and then each of you can give a response. Her question is part of a comment: poverty, limited economic resources, insecurity, and illiteracy are just a few big challenges which further increase the vulnerability of the vulnerable population. And some of these factors are beyond the health sector, requiring intersectoral collaboration. Question is how and what approaches should be adopted to improve health outcomes of vulnerable population in view of these broad challenges, and how successful can we be in overcoming them? Just a really, easy question to start off with.
Yeah. Trust Tahira to come up with that question. So I think it's clear that there's so many different determinants that really prevail upon a lot of populations and that affect their health. And I think that one of the big challenges is that a lot of activities in global health, and certainly a lot of programs in governments, are very siloed. So they don't necessarily align in terms of their impact and their focus and whatnot. I think one of the roles that we can play as partners with government is to try to really understand what are the natures of those influences on health outcomes, and more importantly, think about if there are any solutions that can be operationalized, particularly at the community level. There are things that can be done, I suppose, at the policy level, and there's analysis that can be done at a policy level. But in order to sort of operationalize things, it's important to also be able to demonstrate how these kinds of things can be operationalized at the community level. So Pari might want to talk about this, but for example, one of the major initiatives that we had with our HIV program beginning in India, when we were working at that time working predominantly with women in sex work, was to actually look at what were some of the structural barriers to accessing services or to managing their own vulnerability and risk. And so we worked very closely with the government to address three key areas. One area was reducing violence, the violence that they experienced from people within the community, and even violence that they experienced at the hands of people in police forces, et cetera, and exploitation. So we had a program that was deliberately focusing on training people in the police force, and with leadership from both the police force as well as the community, to try to train police members in terms of how they could actually contribute to reducing the vulnerability and the violence experienced by women in sex work. A second component was accessing social entitlements. Many women were unmarried, or they were divorced, or they, for whatever reason, had a difficult time accessing social entitlements. Even getting their kids into school was difficult. And so we worked with the government, and the government came up with very proactive processes to make sure that women in sex work understood what their entitlements were and gave them access to those entitlements. And then I think a third area was the whole issue of developing a collective voice. So we worked a lot with community-based organizations to try to strengthen their ability to work together on issues and challenges, both for advocacy, but also just to support each other. So there's a number of things, and that wasn't initially part of the design of the public health program, but it was something that could be done very tangibly. And it worked its way then into policy, first at the state level, then it worked its way into policy at the national level. And now if you look at global guidelines for programs for women in sex work that come through the HIV channel, they incorporate a lot of those, not just principles, but actual guidelines around what a comprehensive program should include. And it goes much beyond sort of HIV risk reduction and condom distribution. So I think that those are things that can be incorporated. And I think that once you do that, you have, if you're there long enough and spend enough time at it, you can actually work on the advocacy side of things as well. But it was really crucial in that experience to be able to be working closely with the government, because you can't, as an external agency or body, say, this is what you should do, and then walk away. If you're not working and you don't have the confidence and trust of the government, it's very, very difficult to get those policy changes. And I think, as Vasant said earlier, then being embedded and working closely with the government is really critical, because you develop that confidence and you develop that those relationships really that allow you to sort of help advocate for these kinds of things and provide pathways towards those changes. So that's kind of one way of looking at it.
So, Mary, just to add, as Jimmy was telling, generally government works in silos. I think there are kind of two extreme approaches taken, I would say, in the sense, one is thinking that these are external to health department. You think from the delivery of health services, and you think education or sewage, everything is for others to do, and that will work in a constant pace, and you keep kind of out of it. Other is, obviously, it is multi-sectoral, and everything contributes to health, and try to encompass completely the entire spectrum, and you try to then find very difficult what is to be done. So I would say something in between in terms of some examples. A simple example like hand washing is so important, in terms of reducing infection rates. But we use COVID as an opportunity in the community health platform to really kind of make sure entire antenatal care, both the beneficiary and the practitioner washes hands. Or even in the Japanese encephalitis, which is an infectious disease in some parts of UP, we use the school program to really create awareness and other things. I'm just giving some of the examples where, but say for example, in pandemic, at least in India, it had a huge economic impact on the vulnerable people. You may not be able to do in the short run a lot to improve the economics before bringing the health needs. So there, I think many a times we just need to provide the health services. In fact, irrespective of the fact that pandemic had a huge response onto the economic situation. So I just try to give some examples where sometimes you encompass, sometimes you kind of also take an independent view of it.
Thanks, Vasant. Parinita, did you have anything to add? I'm not sure if we lost you or you switched rooms at least.
Yes, I switched devices and I did lose you for a minute or so. So I don't know what Jamie said, but I will be repeating. I just wanted to say that actually I love Tahira's question. I think when we design health programs, we do need to acknowledge that communities have more pressing needs beyond health, and sometimes some of these needs actually act as barrier to access to health. So I don't know if Jamie said that, but one of the largest programs that we implemented in India with the sex workers, we had to redesign the program because as community consultations happened, they talked about addressing violence in their lives as more important than addressing HIV, and we had to redesign a violence prevention and response program around the HIV prevention programs. So sometimes programs have the luxury to redefine and address other structural issues like poverty or violence and stigma, but sometimes programs don't have these resources, but that services or that extension can be provided by coordinating with other organizations who are providing these services, and through strong collaborations, government and non-government. But I think what's important over here is to consult communities when we are designing interventions, because that's when we will realize that their lives beyond health, and we have to address some of those issues. Thank you, Maryanne.
Thanks. I think there were a lot of themes that really resonated with me around the importance of understanding what the goals are and what the routes to achieving those goals are from the community themselves, and also relationships with the participants in the programs, with the government who's helping support it, or other partners. I think those are really good themes to bring out early on in the discussion. Okay, we have a couple of questions now So I'll save some of the ones that I have for later. One is asking Parinita, can you share more about what some of the impacts of COVID have been on the key populations who you work with?
You're muted. Pari, you're muted.
Managing two devices is challenging. Thank you for the question. And we have been struggling with COVID in Kenya since March 2020. So it's been almost 2 years. And of course, when COVID hit the world, nobody knew what to do. There was panic. So that's what happened in Kenya too. And there was a lot of lockdowns and restrictions, curfews, right? So it affected key populations, especially because sex workers practice sex work at night. And if you have a curfew at 8 o'clock or 10 o'clock, that's what sex work can't happen. But at the same time, the information around COVID, how COVID spreads, actually affected the sex workers' business quite a bit. They didn't have access to sanitizers, they didn't have access to masks, they didn't have access to information generally, right? So that was some of the first things that was provided by organizations, by government and the non-government organizations to them. But what struck me most is that livelihood was one issue. Police violence was other issue, because when you have curfews and when you have restrictions and people try to go out to do sex work or business, they get beaten up and they are fined. So those are two very important things that came up. But the third one that came up, which was very, very critical, was mental health. People our key populations lost their social connections. They got isolated. They either, from a city like Nairobi, they went home where family members were hostile. They didn't understand their behaviors. They didn't understand their sexuality. So a lot of mental health issues, depression, anxiety also came up, and the need for mental health became very, very critical. But besides all of this, what was so exciting is the resilience that the key population showed. When we look at our data, we find that in March and April, performance or access to services reduced. But from May onwards, it just went back to normal, because people found innovative ways of providing services. The clinic appointments happened rather than people coming to the clinics and queuing up. Appointment system worked out. From HIV testing, it moved to HIV self-testing, where the kits were distributed. There was home delivery of condoms, home delivery of lubricants. People, the key populations got together and they generated donations to and provided food baskets to their members, who were especially quite poor. So it, of course, had a devastating effect, and we are still trying to kind of cope with that. The population is trying to cope with that, but it also showed huge amount of resilience, innovation among the population, and innovation, as I said, innovations which have continued to date. Thank you.
Thanks, Parinita. That's great. So the next question, and I think this is for anybody, do you find the challenges overwhelming with the goal of 2030 looming large? It's a really simple question to
maybe let me try, Maryanne. So it's yes and no. Yeah, I would say, because at least what data shows in UP is our annual average rate of change of maternal mortality is close to -7%, which is we are reducing every year by more than -7%, which is one of the highest. And we are more or less on target to achieve the 2030 goals. But at the same time, we also find that the neonatal mortality rate, we need to really double or more than double the rate of annual average rate of change. We need to reduce it much more than what we are doing. But what gives us confidence is that while we have been able to get benefit out of the low-hanging fruits, we have also created pathway for the difficult movements from now onwards, like say, for example, complication management and etc. Similar is the case in terms of reducing newborn mortality. We try to use data to identify what are the main reasons for the death, what are the cause-specific mortality which is causing, which geographical areas are causing, which days are causing more death, and try to kind of prioritize our interventions where we will have maximum returns. I would say we it's more exciting than overwhelming, and we are also equally waiting for the National Family Health Survey Round 5 results, which will show the last 5 years' work, and hope it will be positive in a large sense, so that it will keep motivating us to attain the 2030 goals. So that's my take, but I'll let others also.
Yeah, I guess I think that's really good points, Vasant. And I think for at least for a lot of the specific health challenges, we kind of know what to do, right? So if we're not achieving it, it's because there's a bottleneck somewhere, there's a lack of a system here, or there's a lack of innovation there. So it's kind of like, in a way, it's not as though you don't know that there's a pathway towards achieving it. And it's usually because a lot of places around the world have achieved a lot of these goals. So then the question becomes, how can you achieve that here? And the whole goal setting exercise is also one that, at least within our institute, we've always tried to be very aggressive and aspirational with our goals. If you set very modest targets that you're pretty sure you can achieve, it's usually because you're going to go along the same way that things have been going, and then you take credit for achieving modest goals. Whereas if you have aspirational or very tough goals, it really drives innovation. So as Vasant said, going along at the same rate of decline is one thing, but doubling the rate of decline in mortality, as an example, will require you to actually rethink what the main challenges are, and rethink about different ways of doing it, and thinking about the more complicated or wicked problems that are there. So I think certainly in health, I think it makes a lot of sense to keep the challenges and the goals really stringent and aspirational, but then really understand why you're not achieving them. Because it makes no sense to, I think there's two things you don't want to do with your goal setting. One is to set really modest goals that you achieve very easily. And the second is to achieve goals that are very stringent, but not figuring out why you're not achieving them. Because if you understand at least why you're not achieving them, then you can start thinking through what needs to be done differently. And I think that's really the space that we want to be in, is having real challenges ahead of us, and then thinking through why is it that we're not getting there? Because that's where the value of sort of bringing in science and scientific approaches adds value.
I just also wanted to add one point, that I think we need to be also cognizant that when we are setting these goals, we're also inclusive, right? And it's based on equity, and this whole concept of no one is left behind. So some of our challenge has been the populations that we work with, they are criminalized, they are really marginalized. And how do we ensure that they get all the services and they are not left behind and they are included in this process? And how do we empower them to actually raise their own voices? Also in an environment like Kenya, where a lot of the work or a lot of resources that's coming is actually funded by outside, right? So they're PEPFAR funded resources, Global Fund funded resources. And how do we include these populations when, as we are advocating for domestic funding towards achieving these goals, and they're not left behind? Thank you.
So Parinita, that's a great segue into another question that I have for you, is how do you ensure that everyone's voice and perspective and interests are heard and included when you're planning programs trying to support marginalized populations, sometimes with work that is considered not acceptable or even illegal? I'd love your perspective on that.
Thanks, Maryanne. It's very important question and not a very easy one. But I think I would start by saying that I think one of the principles of programming have to be inclusivity and intersectionality. We cannot consider the populations that we work with as one homogeneous group, and we have to understand that there are a lot of types and subtypes of population, whether it is younger sex workers, women, female drug users, transgender men, or bisexual men. I mean, some of these subpopulations kind of get left out when we lump a population as one population, right? So I think, first of all, understanding and being cognizant that there is diversity in this population, and then, of course, using inclusivity as a principle itself, and from initial stage of whether we are designing a research or whether we are designing a program, to include these voices. Sometimes these voices are very organized, like in Kenya we have a KP consortium which kind of bring all these populations together. Sometimes these voices may not be as organized, and they would be maybe more community groups, peer educators group, which are there in the venues. So depending on the context of a country or context of the program, we will have to identify how these groups are organized or not organized, and how we can include a representation from these groups and include them, as I said, from the beginning of the project, but also create a systematic way of involving them throughout, so that they become our ears and eyes on the ground, and teach us what needs to be done, and how community needs have to be included in our programming. So we have a very good example. A recent example that comes to my mind is the program that we designed with MSM groups in Kenya, or for evaluating HIV testing program, where we included them in protocol development, where they were co-investigators in our program, and they implemented the program, helped us evaluate the program, and now they are co-authors, actually lead authors in some of our research papers. Again, it's not a perfect science or a pure science. It's a little bit of trial and error in some ways, but I think we can do best if we acknowledge there's diversity, and then ensure that they are part of our programming and we listen to them throughout the program. Thanks.
That's great, Parinita. I have a question for Vasant next. So how do you work with the government, the various groups within government, to prioritize which areas to focus on when there may be so many needs and so many different voices trying to get your partnership with in UP?
No, thanks, Maryanne. So one thing is that like goal like SDG goals, which is common to everyone, kind of helps you, because it's like, and you need to attain the maternal mortality rate of 70 by 2030. So, and the neonatal mortality of 12. So everyone is concentrated and everyone knows this is what is the goal is. So that way it helps. So that we don't alter that part. We also chase the same goal. Where do we come in is actually to say, particularly even the inputs part, what Jamie told, mostly they know what to do. It's a how to do part which many a times gets missing, and there's no prioritization there. So we use data again. We use data to identify maybe geographies, maybe days. In the case of neonatal mortality, we just realized that while mothers come for delivery to our community health centers, they do not feel the same as far as taking a sick child onto a community health centers. So why that, why is that feeling? So what service is lacking in our community health centers to give that credibility to the public, so that when a child falls sick in the community, they can bring them back to the community health center. So those are the kind of things where data basically is the fulcrum or the main basis on which that program is driven. But again, when you convert that data into a policy, there's a lot of art which gets involved in terms of selling your ideas. People compete for ideas, so it's just like the shelf in a Costco store or a store. So you need to get into the best place and the best way of getting it. And that's where the art of practice of it comes. And for that, the embedded nature gives you magical opportunities, if not magical bullets, because it gives you lot of opportunities where if you're cognizant of it, you can push your ideas in an effective way. And your performance in one area also brings in credibility so that there is larger audience of it. But having said that, every policy decision will have some winners and some losers. So it's always better to map all your stakeholders and try your best to reduce the feelings of the loser of your intervention, and also give them some other place where they are winners. There are many ways of managing those dynamics, but we must be cognizant as health system policymakers that there are going to be some winners and some losers, and we need to be mapping them, really seeing how we can reduce those feelings of at least, so that they don't work against you. Because in a democratic country like India, Canada, or Kenya, people can go to court, and courts can always put brakes on your interventions. So I will say managing art is also an important part, but it is driven by science, it's driven by the frameworks, it's driven by data. And ultimately, if your interventions are leading to reduction in the SDG goals, more and more people listen to you. If the data shows the other way, obviously the credibility of us is also lesser.
That's a great answer, Vasant. I don't know if either Jamie or Parinita have any perspectives to add to that.
Well, I was thinking back to a couple of things. So one that comes to mind is that Parinita was talking a little bit about the importance of making sure that the more vulnerable populations and those that are generally left behind aren't left behind. And I would say that one of the dangers of this great expansion of the SDG goals, so now we have 17 goals. The Millennium Development Goals are much more narrowly cast. Now you have 17 goals, and each goal has so many different targets. And so even in health, you've got so many different things. So everything from injury prevention and non-communicable diseases and infectious diseases and RMNCH, et cetera. So you have all of these kinds of goals. And so it's sometimes very difficult to navigate that. And what I would say is that if you don't have a very, very deliberate focus on equity, then what inevitably can happen is that policymakers and programs end up sort of being pulled towards the goals that sort of favor the majority, or favor the populations that are already affluent. And so it's like a menu, right? So you have this big menu of all these different kind of goals, and there's a danger that, for example, an HIV response, which has been really, really crucial for opening up health and social services for vulnerable populations in so many contexts, HIV is now going to be drowned out by a number of other goals. So the question then becomes, how do you make sure that the targeted programs that were HIV specific, if they get de-emphasized, how do you make sure that those populations not only don't lose those services, but actually get access to the other services, right? So I think those are things that we're trying to puzzle through, is how do you actually think more through a health systems lens rather than a program lens, and incorporating equity as a really core principle. Because if you don't do that, it's going to be the pressure and the different focus on the different goals is going to, I think, drive a lot of the investments into the majority populations and into interventions and systems that don't necessarily favor the more vulnerable and marginalized populations.
Parinita, did you have a comment for that as well?
No, I mean, not really specifically, but when Vasant was speaking, the one word that was coming to my mind is actually co-creation, right? We don't have an independent agenda. Our agenda needs to be embedded within the government's agenda or the community's agenda. And how do we help them implement it and make it smartly implemented so that we are efficient and we are effective? And when we work with government or when we work with community communities. I think one thing that I have also learned is that you have to be very secure when you're working. You cannot shine. It's not your objective to shine as a technical support unit. Your objective is to make sure that the government shines, right? And you are behind them. So if you are, as an individual or as a team, if you are if you are somebody who likes to be in the limelight, then you have to really go back, because you have to show that the government is in the limelight. So if the Kenyan government scales up key population program with 200,000 sex workers, that's my win. But it can't be me standing over there and saying I helped you. They have to say that University of Manitoba helped them, right? So I think those are something that came to my mind when Vasant was speaking. Thanks.
That's a great way of summing up what was said. So hearing how great this approach is, and obviously I feel it's great as well. Do you think, and maybe we'll start with Jamie, but Vasant and Pari can add as well. Do you think there are lessons that we have learned in our work globally that would be useful to the Manitoba government, the Canadian government, sort of the people who, some people listening might think, well, we know how to do it, and the Institute for Global Public Health goes to other countries because maybe they don't know how to make things better. Their statistics aren't as good. So what do you think that we can take from what we've learned globally and bring it closer to home? And how could we do that?
Well, if I were to start, I think that I think it really begins with the stance and the position of the university itself. So the university has to really think through what is the university's role in society, and if we think about it just in the context of health, what is the university's role in health? And very often we take a fairly detached view of things. We're there to study what the issues are. We're there to do research that then can be published and then presented to policymakers, and the policymakers can read our papers and then they can get great advice about what to do. But it's detached in the sense that there's no accountability for the university and people in the university. One of the things that's very, very different between what I had done and what I've done sort of more in the North American context in academia, and what I see as all of our roles when we're working in the global context, is this issue of accountability. When we're managing or implementing a program in India or Kenya, the results, we're held accountable for results, even if we're not necessarily paying for the interventions. We're still accountable for results. As Parinita said, when we take on the responsibility of providing technical support for a government to scale up a sex worker program across the country without actually funding that and without actually implementing it, that's a very different kind of a stance. So it almost forces you to think through how are we going to develop a relationship that will support this. And if it's not clear that we take responsibility for the results, then I think it becomes very obvious very quickly. And I think that one of the things that I observe in the Manitoba context, in the Canadian context, is that there is too much or more of a bifurcation between what we do in the university and what's happening sort of writ large within the other. We provide advice and we provide our research, but we don't necessarily take on those responsibilities in the same way. And so instead of thinking about it as what are the innovations, what are the public health innovations that we can bring from the global context to local context, it's really more of what is the stance, what is the positioning of the role of us as academics in society. And I think that to me, that's the bigger difference. That's the bigger impact, is sort of reframing what we see as our responsibilities as academicians. And I would say that it happens naturally in the clinical sciences. Obviously, people who are clinical specialists in the university have direct responsibility for running clinical programs. But it's not as clear how that works in public health. and those of us in community health sciences, it's not as clear how what we do is as directly relevant for what's happening in our city, in our society. And I think that that's a difference. The other thing I would say, and I just wanted to point out that there's a lot of navigation and negotiation that happens here, because in many cases, we're being funded by a funder who's based in the US or the UK or Geneva to implement a project. And we have to negotiate space to be a partner for a government. So that's actually a very, very, that can be one of the biggest challenges, is saying, look, we recognize that this is what the funder's goals are, but we have to have an authentic partnership with our partners in the country. So we have to also listen to the responsibilities there. So one of the big challenges we have is navigating and negotiating that space to be an authentic partner and not just be seen as a group that's being funded by an international funder to do a project in a country. And I think that's one of the biggest tensions we face all the time, is how do you navigate and negotiate between a funder and your partnerships.
Maybe just to add, I thought a little bit more even higher level between the pandemic actually has taught a lesson how collaboration is so important at even at a country to country level, and how universities and academia play an important role. Say for example, vaccine manufacturing, almost to the world, India kind of is now the hub for vaccine manufacturing part of it. Even the vaccine rollout, we are close to now 100 million doses in a very short period of time. So those are some of the lessons. But at the same time, we can learn, say, for example, one of the ways of reaching vulnerable population, like what we can learn from Manitoba, is about the entire administrative data that you handle on behalf of government, and how it helps you in having the unitized data on which the entire surveillance system and others move forward. Following the COVID, we had in UP a large amount of fever cases affecting young children and with higher mortality rates, so we were not able to. The other thing is the microbiology department or the microbiology lab can help us in terms of identifying some of the unknown cases of fever and other things still happening in large numbers in UP, where you have dual burden of communicable and non-communicable diseases. So, and ultimately, even the academia for programs, we knew for a lot of time that you put 2 drops of polio, you'll have polio free, but it took us 60 years to really do how to do that across the world. So the how to do part is also equally important to what to do part. So that's where really this particular IGPH, and that it comes in any context. And finally, like say for example, data sciences is an emerging piece where I think again IGPH for Canada as well as for India in UP's context, an example is we are trying to predict using artificial intelligence those mothers who will probably give with high level of accuracy low birth weight babies, because that's one of the most common cause of death. There could be similar data science related techniques which can be learned from India and used in Canadian situation or any other situation across the globe. So I would say there's a lot of cross learning opportunities, particularly in a data driven environment where academia's presence across the globe helps.
That's great, Vasant. Lots of things to think about. We have a couple of other questions. So the first one of them that came in, it says, the folks in India and Kenya mentioned different funders and agencies. Can you tell us about who supports your work in these regions?
I think Jamie can go. Yeah, he knows.
Yeah, I mean, it's been a real mix. So initially, our major initial work was funded by the Canadian government through CIDA, Canadian International Development Agency. But then we've had support from the World Bank and Global Fund, and sometimes countries directly will support us. But a lot of our work, particularly for technical support work, has really been through the Bill and Melinda Gates Foundation. So so I think coming out of their work with HIV prevention in India, they saw this model of providing technical support to government as being a really, really valuable way of supporting big scale change. And so a lot of our technical support work has been funded by the Bill and Melinda Gates Foundation. But we've had a whole range. I would say that the vast majority of our funding doesn't come from Canadian sources. But we get it from the U.S. government through USAID or the UN system. So this is a wide range. But now, and particularly for our large technical support functions, most of the funding comes from the Bill and Melinda Gates Foundation.
Great. And we have another question, and this is a great segue. Somebody is wondering if you could explain how program science works with an example. If you just had a whiteboard, Jamie, you could draw it out for us.
No, I'm going to pass this over to Parinita and Vasant.
Parinita, you would like to go first?
Okay. Yes, I can go first. So the various elements of program science, right? So the first thing that comes to my mind is how we embed science within program, and how program generates the need for science. So science and program, or if you call it science or you call it research and program, are not separated from each other. So we do not do a research because that's a research question for a researcher, but we do a research because that's what the programmers are asking. So for example, because you wanted a practical example, I would give an example of, let's say, our recent project on HIV self-testing. So when this funding came from Bill and Melinda Gates Foundation, and they wanted to understand whether HIV testing services would be a good thing to integrate within the MSM programs, because globally there was very less research on with MSMs and HIV testing. So the first thing we went was, rather than coming together in a boardroom and developing our research question, we actually got together with MSM organizations and asked them what were the challenges with HIV testing in general that they were having, and how did they think that HIV self-testing could address some of these challenges. So the research question that emerged was not only academic research question, but it was embedded within the program's need. And as we continued to do research, most of the time we try to do more implementation research, or we call it program science research, where we are trying to answer the question in the context of a program rather than independently. So the HIV self-testing question was actually we tried to answer within a project for HIV, that we implemented HIV self-testing project in partnership with MSM organizations in 3 sites, and we embedded our research questions within that implementation. The other thing that comes to my mind when we talk about program science is how a program science, because it's research into programs and programs into research, has to have a multidisciplinary team. So it's not about, again, academicians doing research, but partnering with community members, partnering with programmers, and partnering with policymakers from the beginning, and going through this whole process. Like Jamie was talking about, I mean, we have learned about this whole program management cycle, right? You design, you implement, you monitor, you have the findings, and then you influence the policymaker now to accept the findings. So what program science taught us is that you cannot, it's very, very difficult, and it's not at all helpful when we engage with policymakers in the end when we have findings. You have to have policymakers from the beginning and engage them in even the designing the program. They may not be 100% involved like a implementer or a researcher, but they should be part of that design process and the implementation process. So when the findings come, they are already bought into the findings because they have a strong ownership to this to this program. Similarly for community members, because these findings research findings need to be useful for policy, need to be useful for programmers. So if they're engaged from the beginning, not only does our research become very, very rich because we have perspective from different contexts, but it also the uptake of research becomes easier and more useful, actually. So I think these are two elements that comes to my mind very strongly when we talk about program science, and I'll hand over to Vasant to make additions.
No, thanks, Pari. So I'll take again the SDG goal. The reducing maternal mortality rate is our goal, or I'm just taking that as an example. And we go to literature and find what are the cause-specific mortality, major cause-specific mortality. We think that postpartum hemorrhage, preeclampsia, or an obstructed labor. Then you try to find out and which time of the pregnancy cycle is it very critical, and you understand most of the deaths happen in the intrapartum period or something. So then you find out why is it that it happening. You find that complications are being identified. Someone thinks that this lady has an obstructed labor, or if she has preeclampsia, eclampsia, but is she being transported to a center? Is ambulance available? You find yes, ambulance is also available, but you find that their complication is not being managed. Now then you try to find out why complications are not being able to manage, because you don't have the skill sets available and the skill mix available in these centers. Like say for example, as simple as an anesthetist and a gynecologist and a pediatrician who can handle the mother and the child efficiently. You try to find out why it's not possible. Then you try to kind of understand that has other states been able to do it, or other geographies. What Jimmy was telling, already people have achieved SDG goals. Many of these geographies, even within India, there's a study which is being done called as exemplar study, where some of the states, Indian states, southern states particularly, already achieved the SDG goals. You then see their journey, which is around 20-30 years earlier, and they have been able to manage complications by either effective task shifting or by creating specialists and then entering into the public sector. Then comes the nitty-gritty of the, now you have found the research and now the program part, where how do you bring in specialists who can manage complications. So we took two approach. One is to create something called as an entry pathway to specialists who are better qualified than an MBBS doctor, who's an undergraduate doctor. In India we follow the British system, and you are the postgraduate who's a gynecologist or an anesthetist. Many of the North Indian states do not have capacity to take them into the public sector for providing complication-related services. So normal deliveries happen in public sector, complications deliveries happen in private sector with questionable quality and with worse outcomes compared to public sector. So then you create those specialist cadre. In between, you can't wait because these have long gestation periods. We also think whether we can have short-term wins by effective task shifting. Again, you go back to the literature. You see whether effective task shifting has the same outcome, or what does effective means, and what are the policy measures. Some of the policy measures are like legal indemnity, or group incentives, or practitioners choice, etc. So you create a combination of policy measures or enablers to make this successful. So just one example which I thought in real practical application of program science into for a program context.
Yeah, and I think one of the things that both of these examples, these are great examples, thanks Parinita and Vasant. I think one of the things that illustrates is that one of the hallmarks of the program science process is what you're trying to achieve. Like you have a program goal that everybody understands what the program goal is, and everybody's aligned on what the goal is. The process is very iterative. It's to try to understand why is that, what, and there can be a lot of trial and error. So it's kind of like, and then when you encounter a new challenge, you have to develop a new hypothesis and you embed it. So it's a really live kind of an iterative process of research. And so for that, you need to have teams that are actually devoted to that problem. They're not devoted to their own research projects. They're devoted to that problem. So you have, and you need social scientists, and you need clinical scientists, and you need, statisticians and others who can come together to sort of say, okay, these are the questions that are emerging. How are we going to answer that question? And so it really is, the program science is also very much team science, in the sense that you have to have a team of people with different types of expertise that can answer the different types of questions that emerge. And complex public health goals require usually complex pathways And the research is really to help untangle those pathways.
That's great. So I'm going to ask you each, what do you think is the most challenging aspect of the global health work that you're involved in each of your different roles, in each of your different countries and contexts? And everyone's going to take a minute to think. I don't know who wants to go first. Jamie's
I'm pretty
looking
sure
at
it's
the
not
camera.
because there aren't any challenges. It's like, where do you start, right? I'll go first. I'll go first because this is something that's on my mind, and I think that one of the main challenges, at least in my role, with sort of a leadership and coordination kind of a role at this point. I think one of the main challenges is the lack of a coherent global health architecture that sort of addresses things in this way. So the way that funding is organized, the way that academia is organized, the way that incentives are organized for academics, etc. All of those kinds of ways that the overall architecture around global health is designed really counterbalance against this idea of sustained partnerships, complex problems, iterative research, team science. All of those kinds of things, you're constantly sort of trying to move uphill to try to get them done. So I think one of the big balances and one of the big challenges we have is how do you navigate that environment? And I would say that our university has been really, really supportive of this kind of an approach. A lot of the academic institutions wouldn't give the latitude to sort of take this kind of approach to things. But I think the University of Manitoba has been very, very flexible and forward thinking in terms of how it's allowed us to approach these things. But I think that generally the whole academic environment and the global funding landscape really is a countervailing challenge against this kind of an approach.
Thanks, Jamie. It looks like Vasant dropped off for hopefully just momentarily. Parinita, did you have an answer you wanted to share with us?
Sure. I think one thing that frustrates me a little bit is we keep talking about evidence-based, and we have been talking about that for quite some time, almost 20 years, I think, evidence-based, science-based. But I think we still don't look at evidence. It's quite frustrating when I work with various African countries, and for last 15 years, I have been trying to advocate and convince that key populations needs to be prioritized in your HIV response. We have huge amount of evidence about the HIV prevalence. We know that they are most vulnerable, they are at highest risk, but even then it has taken a lot of time to convince countries, and we still haven't convinced all the countries that key populations or some of the other marginalized groups needs to be included in their response, irrespective of the fact that they are criminalized or irrespective of the fact that they are not their behaviors are not morally accepted in your countries or not. There has been a lot of successes, but then it just feels like advocacy never ends, and we have to keep showing the same evidence or generate new evidence again and again and again. The other thing is also about equity, and I think it's quite linked, but also I feel that I feel very special working with an institute which actually puts equity in its vision statement itself, right? Because many a times when we look at data, we look at aggregate data. And when we see 80%, 90%, we feel very happy, 90% coverage. And we don't necessarily go back and look at who are those 10%. And we'll find that those 10% are possibly the people who are most at need. So I think the way we look at data, the way we try to unlock and understand data, and needs to also improve, because that's when we will know who is being left behind, and that's how we can program for the most vulnerable. It's not a frustration really, but I think just wanted to say that the equity lens needs to kind of not cut across not only the programming, but also in smaller things like information and science, so that we understand equity better, and we can program for people who need the most or who are left out of the mainstream program the most. Vasant is back, so I'll give the mic back to him.
No, thank you. I think Jamie would have covered, but let me just kind of give my thoughts. One of the program challenges, like what Parinita was telling, in Indian context, we have this persistent challenge of nutrition related, where there's very less heterogeneity. It has been there for a long period of time, like maternal anemia or stunting. So, but we still know that these have been solved in some places. We are still struggling with how to do that here. So that's where I think really the incentives parts comes, right from publishing. Publication incentives for a program science kind of approach, particularly how do you solve problems, may not be really amenable to the normal way in which a research article is written. So we need to really engage with the publication industries to realign their incentives to encourage more and more, or even arrive at a new model of writing these kind of successes. The second is with reference to the funders priorities, and really managing the population level goals that, say, for example, these SDG goals. Because most funders, I would say, look for short-term returns in terms of what they are putting and what they are gaining out, with very limited post-program, I would say, impact persistence. So that's where the focus on transition and sustainability and long-term engagement in terms of funders' incentive. And the third is, I would say, particularly academia should create many programs at the senior leadership level or executive level for public health leaders, but clearly within a program context. Having studied in US and a public health school, I can tell that at least with confidence that I gained a lot in terms of how to approach and how to get frameworks, but I had very limited. In fact, I never stepped into a public health program context in that public health school when I studied. So I think particularly IGPH with its model is very well placed to really realign the academia partnership for leadership, where the education program can create leaders within the program context, and the program can be, this is suitable both for Canadian context and at least Indian context or any context. We can have best of the institutions giving the theoretical framework, but then the practical part of it is really solving a public health challenge. So these are the three major points, I think, what challenges both looking forward and as on today. I think if we can realign these incentives and solve these wicked problems, the world will be a much better place.
Thanks, Vasant. That's great. And I think it answers a little bit the last question we're going to take tonight, which is, but maybe one of you will add on to this question. What are effective engagement strategies to facilitate knowledge translation, synthesis, and exchange among policymakers, service providers, communities, funders? I think a lot of what you said really did address that, but perhaps I see Jamie has his mic off, so he must on. He must.
Well, I would just kind of reiterate a bit what Parinita and Vasant said, and I think it really is about sort of that. I think it needs to be something that doesn't start at the end of your research, or even after. It doesn't start even after you've formulated your research question. It starts before that. It actually starts with sitting down and understanding what are the challenges that are there, so that you have to then go back and sort of say, okay, what are the research questions here? So I think it's, if you start with, I've got a research question I want to ask, or I've got some research that I've done and I need to get need to get it in front of policymakers. I've never seen that be effective, because there's endless streams of people trying to get the attention of policymakers with their great research. So I think it's really important to start with what is the problem that's in front of everybody, and then you have to go back to the drawing board to say, okay, what are the research questions? What are the frameworks that apply here? And then as the program starts rolling out, you embed your research into the program to try to understand what you're learning. And then the knowledge sort of flows out of the end of that process. But because policymakers and others are engaged through it, it doesn't come as sort of a surprise or something new. They actually have been part and parcel of developing that knowledge base. And I think that it's a process that I think has to be a very integrative and iterative process, right from before even formulating the research questions.
Thanks, Jamie. And that's a perfect way to end. So in closing, I'd like to thank everybody for the super discussion tonight with lots of good questions from people. I hope everyone found it informative and really enjoyed it as much as I did. I encourage you to check out the UM's next Café Scientifique that will take place on January 11th, 2022 on the subject of the Canadian Reconciliation Barometer Project. And the details can be found on the website, umanitoba.ca/Café Scientifique. Thank you and have a really good evening.
Thank you.
Thanks, everybody.
Thank you.
Thanks.